Are non-genital manifestations of syphilis increasing? Please discuss.
So in the last decade or so, we have seen a remarkable increase in the incidence of syphilis in the United States, to the point where we now see at least 10 times the numbers that we were seeing about 10 years ago. The predominance of these infections is occurring in men who have sex with men. And if you look at early cases of syphilis in the United States, about 70% of those men, depending on where you look, between 50 and 70%, are also co-infected with HIV. At the same time, in the last probably year or year and a half to 2 years, we've been seeing what we think are an increase or is an increase in extra-genital manifestations, meaning that these are manifestations of syphilis that can present primarily with neurologic invasion. So, for example, you can see people with chronic headache that turns out to be due to syphilis. You can see people with cranial neuropathies, the most common of these being auditory nerve dysfunction. So people will present with new hearing loss. It's often unilateral. People can present with facial nerve palsies that can easily be misdiagnosed as Lyme disease, which is a real problem, especially if you're in an area where Lyme disease doesn't occur very often. And then people can present very dramatically with ocular syphilis. I would say that that's the manifestation of neurosyphilis that has gotten the most attention in the last several months. Starting in about March, we began to see a rash of cases of ocular syphilis that were noted in the Pacific Northwest, where I live, as well as LA and San Francisco, and then a smattering of cases on the East Coast. Whether these really represent an incidence increase in ocular syphilis, I think remains to be seen. But people are now pretty sensitized to the fact that this is happening, it can happen. And in fact, CDC just sent out a bulletin about this about 2 months ago to ask providers to be on the alert for it. I think the key message with recognizing neuroinvasive syphilis is to know exactly what to ask the patient about. So if you see a patient who has a reactive syphilis serology, maybe they don't have classic signs of primary or secondary syphilis, but you're just doing a general assessment of their health, you really, really, really need to hone in on good neurologic exam and a good neurologic history. And what the neurologic history should emphasize in these cases includes whether there's been any change in hearing loss, whether there has been any change in vision. And when I say that, it's not just visual acuity, but it's also floaters or areas of darkness in the visual field. Those are very concerning for retinal detachment, which is a very bad sign with ocular syphilis, and it can happen. Really want to ask carefully about headache and certainly any other neurologic weakness or numbness or tingling or anything like that. So people need to be very attentive that this can be a very insidious disease. The other extra-genital manifestations of syphilis that we see are all the manifestations that happen after the primary phase. So the primary phase, as you may recall, is just a genital chancre. It's a sore. That can go away, and if people aren't treated, they can come back with secondary disease, secondary syphilis, generally 3 weeks to 3 months later. That's often a rash. You can have hepatitis. You can have nephrotic syndrome. You can have oral lesions that look like oral hairy leukoplakia. You can have condyloma lata, which can be confused with genital warts. So lots of very, very typical but sometimes confusing symptoms and signs. So my advice is to don't think of syphilis. It's called the Great Pretender for a reason, and it has been called that since Sir William Osler termed it that, over almost 200 years ago now. So especially in our HIV-infected patients, especially in men who have sex with men at this time, you really, really have to be concerned that almost anything can present with syphilis.